Okay. So anaphylactic shock is a severe life-threatening allergic reaction. Okay, so when you look back to the scenario, the patient had just had meals, a first few bites, and after that he had this pre-writing grass, and then he had this anxious, he is tachycardic and hypotensive. So it happens because of some allergic reaction. It may be a life-threatening. Okay, it may be a severe life-threatening condition. It can occur within seconds or minutes after exposure. Okay, so the antigen with our foreign substances is someone who is very sensitive, okay, to initiate an antigen antibody response. Okay, some of you may be allergic to peanuts, some of you may be allergic to brinjal, some of you may be allergic to any other substances. Okay, so the substances, why it is happening, because you are sensitive. Okay, you are sensitive to that antigen, and it is very quick, the body is very quick to get these antigen antibody responses. So because of these antigen antibody responses, what happened, your cytokines, your inflammatory response, and then your histamine, okay, they are all activated. Once they are activated, they will all activated more again. 1 minute. Okay, so what happened to this, when you have these antigen antibody responses, your body will activate your cytokines. Okay, your cytokines like your bradykines and all this stuff, and antihistamine or your histamine. Because of this, more and more histamine will be stimulated, more and more cytokines will be stimulated, more and more interleukins will be stimulated. Once they are stimulated, you will have vasodilation, massive vasodilation. Your veins, your capillaries, your arterial world will be vasodilated. Okay, and then this will lead to capillary fluid leakages. When you have capillary fluid leakages, your systemic vascular resistance will be reduced. All the fluid from the intravascular, from your vessels, will be stored in the intracellular. Okay, and then because of this, you will have hypovolemia. If you have hypovolemia, when you don't have enough volume in your blood, you will have hypotension, and this will lead to that decreased venous return. Okay, so because of this, the patient is having tachycardia in order to compromise. Okay, the patient is having hypotension because he is having hypovolemia. Okay, because of vasodilation and capillary leakage. Did you understand? If you have any severe election, okay, severe allergic reaction, this can lead to anaphylactic shock. So what are the causes? Okay, it may be of either any foods or any medications or any bites or stings or any chemicals. All right, so let's see. Okay, so let's see the pathophysiology. So when the allergen comes in your contact with your body, any trigger, okay, it may be of any food particles, it may be of any medication or antibiotics or any bee sting or anything. Okay, the allergen triggers. Because of this, the antigen antibody reaction will start. Once the antigen antibody reaction start, your mast cell, okay, your basophil, they will start producing your histamine, or they will start producing your bradykinin or leukotrienes. Because of this, there will be a massive vasodilation. Okay, because of this massive vasodilation, your capillary leakage will be increases. Okay, so all your blood, they will start flowing from your blood vessel to your intravascular, okay, to your intracellular. Okay, so because of this, the blood flow will be reduced. Once your blood flow is reduces, your tissue is not going to get enough tissue perfusion. Because of this, the patient will go for shock. Okay, and even your cardiac output will be reduced. Once your cardiac output is reduced, there will be reduced tissue perfusion. If you don't have enough tissue perfusion, then the patient will go for hypotensive. All right, so I think I don't need to understand what is venous return, what is cardiac output, what is tissue perfusion. All right, when you are not getting enough venous return from your upper limb and lower limb, if you don't get enough blood venous return in your right ventricle, your left ventricle is not going to receive enough. Okay, sorry, right. So when your right ventricle, right atrium is not getting enough venous supply, your right atrium, okay, right ventricle is not going to get enough supply, I mean enough blood. Okay, if the blood has to come from atria to the ventricle, so if you do not receive enough blood, the same blood that it comes to the atria, it will come to the ventricle. Okay, the same amount of the blood, it will go to the your pulmonary artery for oxygenation, okay, and then the same amount of the blood will return back, okay, to the left ventricle and to the left atrium. So when you are not getting enough venous return, the blood is not going to where the extra blood will come, okay, so the same amount is going to come and then same amount is going to return. So when you do not have enough venous return, you will not get enough cardiac output. So when you do not get enough cardiac output, obviously your body tissue will not get enough blood supply. Because of this inadequate blood supply, you will go have blood pressure, and then the patient will go for shock at any point of time. Okay, so this is about the anaphylactic shock. Okay, so let's see the other type of the shock. What is this? Okay, a scenario: an 81-year-old female presents to the ED with a chest infection. Okay, remember the word infection, the chest infection, and altered mental status. She is febrile to 39-point-degree, hypotensive with widened pulse. Okay, with widened pulse pressure, tachycardic, and with warm extremities. Remember this word, okay, warm extremities. This is very important for septic shock. So what kind of shock is this? Septic. As I told you, hypovolemic shock, cardiogenic shock, and obstructive shock, the extremities will be cold and clammy because the patient is not getting enough blood supply, inadequate tissue perfusion. Because of this, the patient has cold and clammy skin. But what happened in this distributive, especially this septic shock, because of infection, okay, because of infection, the patient have these warm extremities. Remember this point, okay. So coming to the septic shock, what is septic shock? So there are terms that you should know, okay? What is bacteremia? What is septicemia? Okay, when there is transient invasion of circulation by bacteria, when your circulation is being invaded by bacteria, then we term it as bacteremia. But what do you mean by septicemia? So if that bacteria was embedded in your blood vessel, if they are there for a prolonged period of time, okay, then the whole systemic there will be the whole system will be reaction, okay, there will be whole infection of the whole systemic overall body. So that is known as a septicemia. Okay, bacteremia is invasion of the circulation by bacteria, but it comes to once it starts with the bacteremia, they will end with septicemia. How? There will be prolonged presence of this bacteria in the blood. This will accompanied by systemic reaction. This will lead to septicemia. Okay, it will start with bacteremia and it will end with septicemia. So now what do you mean by sepsis? Okay, so SARS, okay, so what do you mean by SARS? Systemic inflammatory response syndrome. Okay, it is a syndrome characterized by presence of SARS is a syndrome. Okay, it is a group of symptom. Okay, characterized by presence of two or more following clinical criteria. When your temperature is more than 38 degrees centigrade, when your heart rate is tachycardic, that is 90 beats per minute. Okay, and then when your respiratory rate is more than 20 beats per minute, okay, when your WBC counts are more than 12,000 cells per ml, then we term it as SIRS, okay, systemic inflammatory response syndrome. Okay, first we will start with bacteremia. The bacteria will invade your circulation, and then it will turn into septicemia, and then septicemia will turn into SIRS, okay, SIRS, that is systemic inflammatory response syndrome. And after this, it will come to sepsis. Okay, sepsis is like you have infection all over the body, you have sepsis. Okay, we term it as sepsis. What this after SIRS, it will advance into sepsis severe. It will then you will come with a severe sepsis. When will we call it severe sepsis? When the sepsis is associated with organ dysfunction and hypoperfusion. Okay, because of severe infection, you will have organ disinfection and hypoperfusion. Then we term it the stage as severe sepsis. Okay, because of severe sepsis, the patient will go for septic shock. So what do you mean by septic shock? It refers to the severe sepsis which is not responsive to intravenous fluid. Okay, at this point of time, your severe sepsis will not respond to any intravenous infusion or any vasopressure, okay, to maintain this blood pressure. When at this point of time, when your IV fluid, when your medication doesn't work, then we term it as septic shock. Okay, are you clear? So bacteremia, okay, the first bacteria will invade your circulation. After that, you will become with the septicemia. Okay, your circulation is being invaded, the bacteria is there in your body for prolonged period of time. It will lead to SIRS, systemic inflammatory response disease. Okay, there will be 4 criteria: tachycardia, your WBC counts will be increased, your respiratory rate will be increased. Okay, and even your temperature will be increased. After that the body will advance into sepsis. There will be clearly identification of infection, and with this severe sepsis, and then with this severe sepsis there will be a point of time when your IVs, when your medication doesn't work, the patient will go for septic shock, okay, with warm extremities. Remember this point, with warm extremities. So let's see the etiology, the causes, okay. Because of bacteria there will be infection. The infection may be because of fungi, parasite, viruses, or other, okay. It may lead to sepsis, and then it may lead to SARS. So all together they combine it and they formed as septic shock, okay. It may be because of trauma also, burns also, it may be because of any pancreatitis also, okay? With all this reason the patient will get infection. Once he have infection they will go for SARS. After SARS, sepsis, and then after sepsis the patient will go for septic shock if we do not treat them properly. All right, so now let's see the pathogenesis, okay. So your blood circulation has been affected, okay, because of this infection, inflammation, okay. The etiology, the pathogenesis are all the same, all right, even for the this septic shock also. So obviously your blood has been infected, and then because of this there will be systemic inflammatory response. Your basophil, your mast cell, your interleukins, your bradykinins, they will be stimulated. Once they are stimulated there will be massive vasodilation. Because of this massive vasodilation there will be accumulation of the fluid in your intracellular, okay. The fluid will be drawn from intravascular to the intracellular. So because of this there will be venous return to the heart will be reduced, and with this the cardiac output will be reduced. There will be less flow to the tissue, and then less supply of oxygen. The patient will be hypoxic, and then this will lead to shock. All right, is it understandable? So coming to the stages of shock, we have 4 stages of shock, okay. The first stage is initiation, and the second stage is compensation, and the third is non-compensation and refractory stage. So let's see the early stage of shock, okay, the compensation. So in this compensation the tissue, the body will try to compensate, okay. Suppose the patient will have tachycardia and hypotension, but at this point of time in this early stage of shock the body will try to compensate, okay. There will be tachycardia just because the body is trying to compensate. The heart is trying to contract it faster to contract it faster to supply enough amount of blood from your left ventricle to the other part of the body. So that the body is trying to compensate to maintain tissue perfusion and oxygenation, okay. The symptom at this early stage of the shock, the patient will be mostly asymptomatic, okay, but the pulse may be slightly elevated because the body is trying to compensate, okay. There will be nervousness, dizziness, weakness, faintness, nausea and vomiting, thirst, confusion, decreased urine output, okay, trauma or other illness, vomiting, chest pain, fevers, or SOB, okay. At this early stage of the shock, in order to maintain this tissue perfusion and oxygenation, the heart and then even your kidney, okay, the heart, your kidney, they will try to compensate, okay, by contracting the heart, by stimulating this RAAA system, okay. So because of this the patient will have almost asymptomatic, but there will be slight increase in pulse. The patient will be nervousness, dizziness, weakness, faintness. All right, so these are the sign and the symptom that the patient will show in order to trying to compensate the early stage, okay. So coming to the non-progressive shock, okay, in this the body is compensated already, okay. Mean arterial pressure will drop by this time where the body doesn't compensate anymore, okay. Now the compensation process is done, the body won't compromise it again. Now mean arterial pressure will drops by 10 to 15 milligram. Your kidney start releasing renin, and then your hormonal changes like your antidiuretic hormone, your aldosterone, your epinephrine, your non-epinephrine, there will be a drastic change in this, okay. And then because of this epinephrine, norepinephrine, and antidiuretic hormone and aldosterone, the basal will start vasoconstricting, okay. The vessels are clamping down, okay. This is non-progressive stage where the body is compensating, okay. So the early stage, the body is trying to compensate. Okay, in second stage, the body is compensating already. Okay, the body starts compensating already. So the kidney, they start producing renin, and then the kidney, they start producing ADA, that is antidiuretic hormone, to reabsorb the fluid in the nephron. And then epinephrine and norepinephrine, they are the vasoconstrictor, vasopressin. So they will release this hormone. This hormone, they will start compressing the, they will start clamping the blood vessel. Okay, now intermediate progressive. Now after this progressive, now the patient, the another advanced stage is intermediate or progressive shock. In this is also known as a decompensated. Okay, decompensated. The mechanism compensate for worsening shock will begin to fail. Now the compensation mechanism will start to failing. Okay, gradually. Cellular dysfunction begin to spiral out of control. Your metabolic acidosis worsens. Okay, in this maps, okay, your mean arterial pressure drops. There will be hypoxia, anoxia, ischemia. Okay, in this third stage, that is your progressive shock, the body start decompensating. Your compensation mechanism, it works. Okay, it fails gradually. Now coming to the refractory or irreversible shock. Okay, the name itself, refractory or irreversible shock. So there will be lack of O2. Okay, there will be increase in toxin. Okay, just because your mechanism, your compensation mechanism fails. Okay, but it is very difficult to recover also. Your enzyme activity increases, your tissue anoxia increases, and at this point of time, the organ starts failing and the shock can no longer be reversed. Okay, by the name itself, irreversible. So where you cannot where the condition cannot be reversible again. Okay, with the fluid or with any medication. Because of this organ dysfunction, the shock cannot be reversed anymore, and that occurs rapidly. So this is the stage. So what are the stages? They are the early stages where there is compensation, the non-progressive where there is compensated, and the intermediate or progressive where the compensation mechanism fails already, and is refractory or irreversible where the where the intravenous fluid or any medication doesn't work anymore, where at this stage the organ fails it and the shock cannot be reversed anymore. Okay, all right, is it understandable or am I too fast? So now coming to the clinical manifestation. Okay, when the patient go for shock, okay, the patient will have some exhibit sign and symptoms. Okay, central nervous system, in central nervous system they will exhibit some sign and symptom: cardiovascular system, respiratory, renal, gastrointestinal, hematologic, and anticoagulatory system. So coming to the central nervous system, the initial sign and symptom will be, the patient will have restlessness, okay, agitation, anxiety. Okay, but as the shock progresses, the patient will become confused, now lethargic. Okay, because there is decreased tissue perfusion to the brain. So obviously the patient will go for confusion and lethargic. Okay, and then finally the patient will become unresponsive. Coming to the cardiovascular system, there will be a drop in blood pressure, because during the compensatory stage there will be normal or slightly increases, but as the shock progresses, your compensatory mechanism fails, the patient will go for hypotensive. Okay, and then even pulse, during the compensation the pulse will be tachycardic, will be greater than 100 beats, but as it progresses down, the pulses will become brady. Okay, and your jugular vein, okay, in case of obstructive and cardiogenic shock, okay, the jugular vein will be distended. Okay, it will be distended, and what will happen to your capillary refill? It will be delayed, which indicate you have peripheral hypoperfusion. Okay, so these are some of the signs and symptoms that the patient exhibit. And what will happen to the central venous pressure? Okay, the central venous pressure will be increases. Okay, in case of distributive shock, but in case of hypovolemic shock, it will be decreases, because in hypovolemic shock you are not getting your blood, or either your body fluid is being lost. Okay, either your blood volume or your body fluid is lost. So because of this blood volume decreases and the vascular competences, so central venous pressure will be reduced in case of hypovolemic shock, but in case of distributive shock the competence will be increases. Okay, so in cardiogenic shock the central venous pressure is increased due to poor myocardial contractility. All right, so Coming to the respiratory system, in early stage of the shock, the respiration are rapid and very deep. But as the shock progresses, all this, the breathing will become shallow. Okay, the respiratory muscle will become weak. This will lead to the shallow, deep breathing. Okay, with poor gas exchange. And coming to the renal system, oliguria. What is oliguria? There will be decreased urine output. Okay, the urine output will be reduced. There will be concentrated urine and increase in the blood urea nitrogen creatinine levels. Okay, which is a sign of shock. Okay, coming to the gastrointestinal system, so what will happen to the GI system? Your bowel sound will be decreases, and then your nausea, you will have the feeling of nausea and constipated. Okay, and then because of this hypoperfusion, you will have the high risks of getting infection and sepsis. Okay, and then because of this hyperperfusion, your liver will not be able to produce coagulation factors. When you do not produce this coagulation factor, there is high chance of getting thrombolytic. Okay, and then the clotting disorder might come, drug toxicity might come, and increased susceptibility to any infection may occur. Okay, coming to the hematological system, so when there is interaction between infection and inflammation, anyway your sepsis is going on, your SIRS is going on. So because of all this thing, okay, there will be a problem in clotting. Okay, this will inhibit fibrinolysis. So because of this, there is high chance of bleeding. Okay, plus there is high chance of forming clot also. Okay, decreased platelet count maybe is a possible risk factor. Okay, and then there will be petechiae or ecchymosis. Okay, there will be bleeding of your capillary or your veins or your small arteries, which will which is known as a petechiae and ecchymosis. Okay, they will occur along with the blood in the urine, stool, gastric aspirate, or tracheal secretion. Okay, so these are some of the signs and symptoms, the clinical manifestation that the patient exhibit when he or she undergo shock. Okay, so coming to the anticoagulatory, okay, there will be cyanosis, bluish discoloration. Okay, and then what happened to the in case of hypovolemic, cardiogenic and obstructive shock, the patient will have cool and calm skin. But in case of a distributive shock, especially the septic shock, the patient will exhibit warm extremities. Okay, because of all infection. Okay, so these are some of the signs and symptoms specifically to the hypovolemic shock. You can go through these slides personally. Now coming to the assessment, coming to the management, so how are you going to manage it? Okay, so how are you going to manage it? Okay, so coming to the empiric criteria, so what are the criteria that we require in order to classify it as a shock? Okay, so just go through the slide by yourself. Just let's see the diagnosis. Okay, so now we have to go for the first thing is history collection. All right, so I don't need to explain in history collection what are the kind of history that you need to, any kind of infection or any severe allergic reaction or any kind of severe reaction to any drugs, foods, or any sting bee, or and then any history of so what kind of history that you are going to take. Okay, all these kinds like related to your diets. Okay, related to the allergic reaction, related to any injury. Okay, these are the things that you have to go. And then the presentation, the patient will, as soon as the patient comes to the hospital, the mean arterial pressure will be less than 60 mm of Hg. Okay, and even your serum lactate will be increases, which shows that there is some kind of infection going on. Okay, your serum bicarbonate will be decreases. Okay, and even your systemic oxygen level will be less than 60%. So coming to the laboratory test, so there are some of the lab tests that we have to go through. Okay, so in case of hemoglobin will be your decrease in case of hemorrhage. Okay, your WBC will increase in case of the septic shock and anaphylactic shock. Your neutrophils will be, obviously it will be rise because there is acute infection going on. Okay, and even your monocyte will be rise because there is infection going on. Your eosinophil because will be rise if there is any allergic response. Okay, especially if you have anaphylactic shock. Even your kidney function will be this range. Okay, your blood urea nitrogen will be too much, your creatinine will be level will be too much, even your cardiac enzyme like aldehydes, cpk, mb, sgot will be increased, even your serum lactate will be increases in case if the patient have this septic shock. Okay. So serum lactate is very important to diagnose this septic shock. So coming to the other diagnostic tests, in case of hypovolemic, we can go for USG and CT if there is any leakage of the fluid or if there is any loss of the fluid. In case of a cardiogenic, because there is blockage in any of the in any of these your coronary arteries or in any of your pulmonary arteries. Okay, so we can go for ECG, echocardiography, and even your cardiac enzyme. In case of the obstructive, we can go for angiography or venography, Doppler, X-ray, CT, MRI, and echo.